Microphone check. Good morning, everyone. Thanks for being here today for our joint Planning and Finance Committee. Mr. Montgomery is unavailable, so asked me if I would sit in for him as chair, which I'm happy to do. We have a quorum, and so we're going to go ahead and get started. I'm not aware of any citizens wishing to address the committee. Would anybody like to give me a motion to approve the September 23rd minutes?
Second.
A motion and a second. Are y'all getting all the motion and seconding over there? All right. If not, any questions? All approved, please raise your hand. All same sign. See, I'm zooming.
I know you are. You are. You put your vote in the chat.
I've got so many Zoom things. It's like this. It's like because nobody hears anybody say "I" on Zoom.
I know.
Too many.
I thought,
too many
okay.
committees. Too many boards. Okie dokie. Sharon, rescue me. God, please rescue me. CFO report. Welcome and good morning.
Good morning.
Morning.
So just an update on our external audit. The BKD auditors began this week. They'll be on site for about 3 weeks. And we do have a pretty expedited audit. You'll see the final presentation from Chris Clark with BKD at the December 16th Finance Committee. So really the only change I would anticipate between the numbers that I'm going to present to you today and the audit is if there's any additional guidance on the CARES Act recognition. But I've got a couple of slides to go over with you later that will help explain some of that. That's my only update today.
Fantastic. We appreciate it. Okay, well, let's move right on into our matters of discussion requiring action and our unaudited year-end financial report.
So it is year end. We are wrapping up our 12 months as of September 30th. And I'm not going to cover my normal slides, although you do have them in your book as distributed. I prepared a little bit different view just to kind of wrap up our year to date. Just to go over our kind of our normal key statistics, you can see that I looked at kind of a 3-year trend here. We did this during our budget presentation too, so I won't belabor the point, but you can see our admissions have declined each year beginning probably in March of 20 with the onset of COVID, and those volumes have not yet fully recovered. However, our length of stay has increased, and you'll see that even though our admissions are down, our patient days are not quite as far down. They're about equal to prior year. So when you look at our CMI, you can see that that has gotten much larger. The biggest driver here is probably those COVID positive patients. If you look at it right now, the overall CMI is 1.81. And the reason that our CMI is so important is this is a multiplier for a large number of our inpatient payments. So somebody with a CMI of 3 would get roughly twice a payment for someone with a discharged case mix index of 1.5. So a slight change here really ramps up our collections, and you'll see that as in a different slide. If you look at just our COVID CMI patients, they are at a 2.33. Those accounted for about 5% of our total discharges this year, between 5 and 6%. And our non-COVID are just below that 1.8. So they do have a significant increase in acuity. Our length of stay is about 5.7 days. That's from the time a patient's admitted to the time they're discharged, and that's about 10% higher. It does typically track with their acuity. Our emergency and our behavioral health emergency departments have a different experience this year. We've about kept even with prior year for ED, but we have seen a return, actually a pickup of volume from 2 years ago with the behavioral health population. In our primary and specialty care visits, the top shaded portion, just as a reminder, is our telehealth. So we are, in primary care, we have made up some of that volume with those electronic or phone call touch points. Our specialty care volume, you can start to see that has increased this year about 15% from prior year. Surgical volume, this is highly impacted by some of the closures that we've had for elective surgeries. You can see that our inpatient surgeries have remained pretty stable, and our outpatient surgeries are beginning to recover to a 19 volume, but we're not quite there yet. And then from a behavioral health standpoint, our days have remained relatively constant, and you can see that our clinic visits have really picked up since 19, but a large portion of those are telehealth visits for that population. When you look at AR days, we calculate this kind of as a point in time. There are challenges with some of our payers. There are some large payers that have begun to delay payments slightly, but we're still working through those accounts. But we've closed the year at 42, which is still very good relative to an industry standard. And our FTEs per adjusted occupied bed actually fell a bit from last year. But just as a reminder, even though our acuity is up, we are really having issues filling some of those open positions. So that has kept us lower at that 5.84 this year. Our days cash on hand, this graph looks quite a bit different than the last time you saw it last month, and it really has to do around the CARES Act funding. The shaded portion, we were kind of holding that COVID CARES Act receipts of $87 million on our balance sheet. We did not want to go ahead and count that until the final guidance was out and we were able to determine we could keep that CARES Act funding. So with the CARES Act recognition, we did achieve a calculation that allows us to recognize all of that CARES Act money that we received. The guidance has changed a lot in the last 3 months, and so we went ahead at recognition. We put that back into the operating cash, and that represented about 30 days of cash that we were kind of holding on the balance sheet, and now that $87 million, we believe that that is ours to keep because of our losses with revenue and those increased expenses. So right now, we're closing the year at about 310. The rest of that shaded area is really the Medicare advance funding that we will eventually pay back by the end of FY22. So we got kind of paid in advance for work that we are going to be performing throughout the year. So right now, without the shading, we're at 297 days cash on hand. That is extremely important as we start to enter into the first phases of our construction projects. So this is our income statement. Looking at just the year-to-date numbers, you can see that there were some pickups at year-end. Most of those are around the final calculations of supplemental Medicaid funding, and in our non-operating revenue, we did have that recognition of the $87 million. So we are closing our year with a net income which includes that CARES Act recognition of just over $360 million compared to $128 million budget. And I'm going to cover some of those larger variances in net patient revenue, kind of to show you where that 81 million came from. We're going to talk a little bit about the supplemental Medicaid funding, and we're also going to talk about the CARES Act recognition. So some of our larger pickups at year end, again, is some of these increases in uncompensated care, DSRIP, and disproportionate share. That was $70 million this year. Around uncompensated care, when we did our budget last year, we were not quite sure how formula funding would work out. If you recall, about 2 years ago, HHSC, based on CMS guidelines, changed the way that our portion of that pie is calculated. So we were a bit conservative, expecting some decline in how the formula funding works for us, but it was favorable this year. And then on almost all of these categories, they were impacted favorably by the public health emergencies that were in place, mainly through what we call an enhanced federal matching percentage, which means that we don't have to put as much money up, and that therefore our net is larger. So for uncompensated care, about 2/3 of that was the formula funding pickup, and about 1/3 of it was for the concessions that were made around COVID. For DSRIP, that was $18 million. About $15 million of that was impacted by an enhanced FMAP. So that was a COVID concession. And we achieved about $3 million from prior years. We don't budget for a prior year achievement, but if we do get it, it's kind of a windfall. The DSH number was also in large part by an increase in the federal allotment, again, a COVID concession, and about $10 million was legislative, and that we were told there was going to be a decline in the federal pool, and they changed that. So that was about a $10 million pickup for us. So over half of that $70 million resulted from concessions in one way or another to help hospitals through the pandemic. And those were not budgeted for next year. We're just not quite sure where things are going to land with the public health emergency and the extension of those programs. And then there are larger questions around some of our supplemental funding as HHSC and CMS works through the new state fiscal year. We had a favorable amount in our tobacco payments. We did have favorable UC settlements. Those are settlements that are coming through our cost report. Our discharges were down, and Medicare is trying to give us a per discharge, but it's lower volume. So we'll get another almost $10 million at the end of the year through our cost reporting to get us up to their allocated amount. And then the CARES Act funding is by far the largest recognition at just over $87 million.
So Sharon, did we not realize any opioid funds for year end?
No, sir, we have not.
Well, that'll be next fiscal year 21, 22.
If we receive them, I'm not quite sure where we are in that process right now, but those would be recognized as we receive the cash, Trent.
And do we know yet what's going to happen to DSRIP?
Let me get to a couple of slides and I'll give you what I know.
Okay.
We did receive some communication this week from HHSC, and there's a lot of questions.
Okay.
Sharon, on the Medicare advance payment during COVID time, how does it affect the current claims coming in? Is it offset on the 837, 835, or how does that
So
work?
there is a portion, I can't remember the percentage, but when they calculate what they owe us, they'll pay us 80% cash, and then 20% we get to recognize out of that advance payment.
Okay.
But it is a certain percentage of their cash due. They don't take it all off the top. They're kind of easing it in. If it is not repaid by the end of, I believe, the state fiscal year, we would have to pay that back in a lump sum. But we believe that we will be able to draw that down to zero by that time.
Is that like a different column on the EOB? The reason I'm asking is to make sure that Epic can read the EOB correctly, so it won't affect a bond rating later on, because they may not treat it correctly and it could be underpayment of some sort.
Okay, we can visit about that, but it's nationwide, so, and I can also reach out to our bond advisors and make sure that the rating agencies, Standard and Poor's and Moody's, are generally very understanding of what we're having to account for through the CARES Act. I've had a few updates and phone calls with them throughout the last 2 years, and but we can double check on that.
I just want to make sure they properly allocate it so that it won't affect our bond rating, because if they show that partial payment, underpayment type thing, as we go through the bond rating, it may affect us.
Okay,
Thanks.
yeah, we can work, and we can also educate as we go through that rating process too.
Okay, thank you.
Ooh, an extra one.
Yeah, DT has definitely earned his fruit back there. So our net patient revenue, as you saw on a few slides before, we were able to collect about 80 million more than expected. The largest part of that is around this Medicare managed care UC. There are two things going on here. We did budget for an increase, but we got a larger increase than budget, and these are paid per claim. And we did not budget enough in the managed care, the MCOs that are used for Medicare. So this is this is just a comparison to what did you budget versus what did we receive. The other large pickup that I talked about earlier is just a payer mix. We've seen a lower percentage of self-pay overall, and each small incremental decline in our self-pay has a very large impact on what we're able to collect. One of those COVID concessions was through HRSA, we're able to bill them for a self-pay patient that has a COVID positive diagnosis on discharge. And we get a Medicare rate for that, and that might be driving some of that payer mix. Our CMI that I talked about on an earlier slide, that 7% increase from budget accounted for about a $12 million pickup on our collection rate. URIP, which is a program that it is a supplemental payment program, but we recognize that through the Medicaid MCOs as a higher payment. When we closed our budget, we thought it was going to be 1%, and we actually ended up getting about 13% higher. So again, that is part of the supplemental funding that we have in Texas. We did have about a 20% Medicare add-on for a COVID positive patient that is paid under Medicare. 4.4 million pickup there. And all of that was, I'm sorry, that was 1.6. And the volume impact was a negative because our volumes are down overall to about the tune of $8 million. So that's where that 80 million came from. And then Trent, to your question, there's a lot going on with supplemental funding, and I've really covered what's written on this slide, so I'll just have a conversation about what I know for next year and how it might impact us. The one thing that we know is CMS has not approved any of the programs for HHSC. They are talking, but we don't have any of the details. So UC is a program that continues as is through fiscal year 22. So we do have a good understanding of what's happening there. For DSRIP, CMS offered to extend DSRIP, but we don't have what measures are going to look like. And so there's a lot of details to get worked out, and that program has not been finalized by CMS. Under the current URIP program, we have not got a final word from CMS that URIP may continue. Now, HHSC is still collecting our IGT. Remember that IGT has to be collected months in advance because those are payments that run through claims managed by the Medicare MCOs. So it's a very complicated program. But we are waiting for that program to get renewed and approved by CMS. The current URIP program did stop payment in August of this year. So it's been suspended, and we will likely start to see some variation to this next year's budget. CMS not only has to approve the program, but they would also have to make a separate approval for retroactivity. So we'll have to see where we land there. And then CHIRP, which is the new program as the URIP and DSRIP were coming to an end. HHSC is collecting IGTs for those, even though we do not have CMS's final approval on that program. So there is a lot of unknown as the state and the federal government work out these supplemental programs in Texas. But it's at the top of a lot of people's radar.
Well, stay tuned.
Stay tuned, yes.
But I will say, it's a whole world different than what it was 6 years ago when we would go down to Austin and fight for our fair share of every one of those categories. And we were on the short end of that stick, and there was a picture of me with a circle and a line through it with all of our private, and not you were getting phone calls and how horrible I was and how everybody hated me in Austin. And we are not in that situation now, and it is a nice situation. And the funny thing is, I don't receive any phone calls from my colleagues about anything I'm doing wrong right now, so I think they're all happy with that funding too. So it is a much better situation, and I appreciate your caution because you're dealing with government entities and things can change very, very much, but it is definitely a better place than we were 6 years ago when we were trying to put nickels together and they were taking dimes away from us.
It's definitely everyone, all providers are in the same boat here until these final regulations are finalized.
Quick question on the coding side, and you may not have an answer, we can revisit later. But in terms of, we have a high CMI because of COVID and all that stuff, and we have a pretty good population for MA plan also as well. Have we seen the uptick in reimbursement for the physician yet from sicker patient that we have since 2020?
So I'll have to look at that. From the physicians, they are paid based on more of a procedure code versus a CMI. So assuming that there are more procedures that are happening,
Because I'm not sure if, if they have COVID in 2020 or 2019 and 2020, can we still code it for ongoing? Because it can be lingering effect that carry on and that change the RAF score. And that's how their reimbursement may change on the Medicare Advantage, not the regular Medicare. Yes, right.
Sharon, I
okay.
can give a quick answer. So DT, great question. In the data that we have for the MA plan where we have the most concentrated information, our RAF scores have gone up. I would envision they would continue to go up. It will be difficult for me to discern if that's the impact solely of some of this complexity versus our ability to do it, because we've been training and educating individuals in what is a new skill set. To your point, my understanding is there is still some debate about how to code COVID for its complications long-term. And I don't know how that's going to play into the risk factor scoring and where and how it could land in HCCs. You may actually know better than I, but we've been exploring that. So,
Because I'm more concerned is that the Medicare side, Advantage side, and the company, they're short on staff, but they can't make appointment because of, so they're not updating the profile, the RAF score and all that stuff. And then we get penalized. So I just want to make sure that we double check that. It's not something that we do, but we have the right to ask them to see if they do their job.
excellent point. We're working on it. We're actually trying to come up with some innovative ways that we're bringing everybody in before the end of the year, as many as we can, for that very reason.
Okay, great. Thank you.
So these next couple of slides are over the CARES Act funding. We have received $87.4 million back in 2020. If you recall, when we closed our year, 2020, we did not have any guidance that was really clear. So we worked with our auditors and we deferred any recognition until more guidance was available on the recognition of those funds. So we were able to recognize the full 87. When I talked to you last about the CARES Act, I was confident that we would be able to recognize about half of those. And what changed between then and now is we were instructed to look at an annual basis on our fiscal year for lost revenues as well as increased expenses. Very recently, we were able to measure lost revenues based on a quarterly view. So the first 2 quarters, we had some really large losses of revenue, and then in subsequent quarters, there were a couple that we actually picked up revenue as we started to open up in some of those 6 quarters we were looking at. Which were offsetting the earlier quarters. And when we were able to utilize that quarterly view, we were able to go ahead and pick up quite a bit of recognition. The guidance boiled down, we can use those funds, and I say it on the slide, to incur expenses incurred to prevent, prepare for, and respond to coronavirus. And then we could also use that for lost revenue. Some of the expenses, the larger expense is staffing. We were able to go back in and allocate direct and indirect costs for those patients that were COVID positive, as well as some of the extra lab testing, PPE, some of the expenses we incurred standing up our telemedicine. And then there were miscellaneous supplies and equipment that were specifically identified. I do want to give credit to my accounting staff and all of the effort from the operational folks who spent time. And in March, we sat down and started creating cost centers and places to code all of these extra items. This was a monumental task. And I can't even quantify how many hours it's taken. But operations has been wonderful about identifying these expenses. They worked very closely with my controller, Courtney Bodecker, who's really tried to organize this as well as possible. And then Courtney has been working externally with our auditors to make sure that we are all on the same page as we closed our books. And then I've already talked about how we chose to look at lost revenues, and because our budgets were approved at a certain point, we actually took the difference between our budgeted net revenue and what actually came in on each one of those quarters. As a reminder, Acclaim did receive as an organization $530,000. We recognized that at the end of 2020. All of that was already recognized. And then DT, your Medicare advanced spending question, I think I've covered it. We do expect that we will have repaid the $37 million that remains on our balance sheet right now by the end of our year. And then on a claim, they received a much smaller amount, and we have completely had those recouped by the end of this fiscal year. No, our fiscal year. Yeah, so a claim has, when you look at 9/30 of 21, we do not have any liability left for that $322,000. And on the medical center, we have the 37.2 as a liability, but based on our claims payment, that will be repaid by the end of 9/30/22. So, does anybody else have any questions about kind of the year end that's happened? I covered a lot of information, and it's not my normal presentation, so I appreciate the conversation.
Thank you and your staff for a ton of work and actually getting it done in what I consider record time, given what we had to deal with over the last year. So fantastic job, and please pass that along to your staff, Sharon. They did a great job.
Oh, well, thank you. For a claim, it's a shorter story. We didn't have a whole lot of change that happened. September was a normalized month for them. You can see that our encounters here are growing slightly, but they've not resumed to the 19 volume. And we closed a claim at a loss of $34 million compared to their budget of $47. So about 25% favorable. A lot of that has to do with some of their open positions. We had favorable variances in salaries. They were able to also recognize about $5 million of net revenue, so expected collections were up as well for our physicians. And then one thing, this is really just housekeeping, but if you recall, one of our BKD issues in prior years was the fact that we have, we fund a claim as an investment to our system. And we voted as a board to go ahead and reclass that at the end of each year for these financial reportings. There's no impact to cash, and it doesn't impact the income statement. But we did want to tell you at the end of every year, that amount this year was about $37.7 million. Again, it's just a balance sheet reclass, and it goes from a receivable into an investment within our fund balance.
The BKD's reconciled themselves to that, and they're good with that.
Excuse me?
BKD has reconciled that and is good with that
Yeah,
methodology?
if I don't make that reclass, they will make it for me.
Okay.
So we might as well just go ahead and do it. I don't like reclasses. So our GEP board update, while I have you here, I'm going to take a few minutes just to update you. There haven't been a whole lot of changes in the projects that have been identified, although we have moved forward with quite a few. And the column at the right is recognition through August of '21 of real savings that have come from some of these projects. Again, I do not believe that there's any brand new issues here, but some of our, and these are organized from our implementation date, if that makes sense. So the earliest one was in March. Again, we started these projects back in early January. So lab services, again, it was just really talking to the incumbent. We project about a $250,000 savings annually, so any given rolling 12 months. And through August, we've recognized 125. One of the biggest conversions that we did was in our distribution vendor. We were able to reduce the distribution fee fairly significantly. That accounts for about 450 of that 1.2 million annually. And we also have had opportunities for product conversions, and that accounted for the rest of that. To date, we have realized about $780,000 of savings there. A smaller one is the oral, the OMFS implants. That started back in April. We've gotten about $270,000. Our interpretation services were rebid. A big pickup there is that they were able to give us some of the equipment up front, and then we were also able to project out about a $550,000 operational savings. If you recall, you approved those again back in March, and those are two really large contracts. And our travel policy update, we've been working with a travel agency to make sure that we get favorable rates on hotels as well as airfare. We haven't really received or recognized any because we have very little travel occurring right now. And then those that are still in process, we think that these will probably happen in the next couple of quarters, but you can glance through that. For cardiac products, podiatry products, hand trauma, ortho trauma, and sports medicine, all of these are trying to get to more of a focused spend with a preferred vendor and get us to a better pricing tier is how we would achieve some of these savings. And supply chain has been working very closely with those physicians that touch these products. So it is a work group and a work session. The physicians have been incredibly responsive. There are some honest discussions that are happening here, and all of these projected savings, although they may change slightly, we'll be able to implement those because we're dealing with the users and choosers of those products. So overall, an annual savings, we're at about a $3.5 to $4 million savings right now. But we have realized a little over $2 million of savings through August.
So let me ask a question. These are all O&M, general fund, budgeted items.
Mm-hmm.
Do we have a method to track capital in the same format? For example, the cancer center decision. I think if we could begin sort of framing our capital expenditures relative to savings and budget going into the bond program, I think that's going to serve us well. And I think we should have that in a format that we could almost just be able literally to hand out to people, because more and more people are starting to now look at the bond program, ask questions about the bond program. There's going to be questions about budget. We've seen even articles today on that. I'm just not sure we've gone as far as we should go in terms of transparency, if you will, relative to how we're tracking the capital the same way we're tracking O&M.
So I'll give you what my vision is for the tracking of the 1.2 billion projects that are on the table. I've been working with Adam and Derek with Broadus, and we are close. They're close to providing us, the work groups, with kind of a list of what the original projects were, very, very large summarization, versus what the projects might look like today at today's prices. Taking into account there was an allocation for a cancer center, and now that's done. So just trying to balance back to that 1.2 billion of expenditures that we're looking at. That will help me figure out if some of these earlier projects are going to be able to be funded in the larger 1.2 billion, or if we're going to have to go and find some additional operating cash for those preparatory projects that probably will hit in phase one.
Good. I think that'll help us. I know on the steering committee, we're going to be really diligent about tracking those projects relative to initial estimate.
Yes.
And we'll have to take into account operations costs. We'll have to take into account material increases. I mean, all those things that happen, we have to look at. But I just think a global, real simple, easy to understand capital comparison relative to where this starts and where it ends is going to be helpful, because JPS does not get much credit for saving money. We get a lot of credit for spending money, but there's a lot of things happening right now at JPS on the capital side, from the IRMA implementation and the life safety changes that we've made, that relative to budget are tangible and some intangible savings that I would love for us to be able to empirically illustrate to people.
Yep. So I would like to be able to have like a one-page summary. I'm sure we'll have more than enough detail behind that, but I think that's step one, and we hope to have that in the next 4 to 6 weeks. And then on your operational comment, since this is planning committee as well, I do, from a timing standpoint, once we get the projects defined and the phasing begun and what services will go in each one of these buildings, then we really start the financial deep dive into the impact to the operational budget. So we're probably a good ways out from seeing a financial view, because those projects obviously have to be defined prior to us putting a dollar value assumption to those.
You articulated that really well, and I don't know that Steve Montgomery could have articulated
couldn't
it
have,
as
I can
well.
guarantee.
You being chair today, he wouldn't have done that. But I will say that I made that point Tuesday at the Commissioners Court, to that very point that we really don't get the credit when we save. We had discussed $90 million for a cancer care center, and we were able to do that by leasing property and a retrofit of it for about $6 million, and then the lease. That's a huge savings. And we know we're going to have fluctuations in the cost of material and product and cement and everything else in between. But I do think that Sharon and the team and the capital expenditures and the work that planning's doing has been pretty smart about how we're going about doing that. And I think we just need to articulate it better. I don't think the public's criticizing us. I don't think the public knows. And I think we would do a better job of allowing the public to understand what we are doing with their money and how we're spending it in a wise way.
Yeah, and even if it's not, we can't be conclusive at this point, and we know that because so many things are yet to occur. But even if the format of the report is designed in an iterative fashion to be able to take credit for those things that we have realized already, like the Cancer Center. Then we're not having to wait a year and a half to see how that trues up against some operating. I mean, this keeps it moving forward, and it keeps something that everybody's got their hands on. And I think, because Robert has, been told he's gonna report to the Commissioners Court every month now on status of the bond program. I would love to equip him with information that frankly makes for more intelligent talking points than some of the things that are concluded from that meeting. It's a lot of data, it's a lot of material, it's easy for it to get confusing. I think keeping it simple, iterative, and being able to pass it out to people, that's where the sound points are coming from, that's where the talking points are coming from. Because we can spend an hour and a half on this data, and there's not a dozen people listening to it will really be able to understand that and apply it. So I think it's up to us to kind of make it simple, make it iterative, illustrative, and transparent. I mean, these are real dollars we're talking about, and we're trying to be as absolutely careful with them as we can, and our staff is focused on that, and there's been even value engineering relative to expectations on IRMA. There's been a lot of that, and I'd really like to see that stuff become a little bit more obvious.
I think we can do that, and I think Sharon and her team have learned a lot about how to articulate that, and Adam and his team combining can do that, and I think we'll be in good shape.
Good. Thank you. Sharon, anything else?
Not for me.
Does that complete your report?
It does.
Awesome, thank you. Well, then we need to take action on that, do we not?
Yes.
All righty, so you've heard Sharon's report. Do I hear a motion?
Move acceptance.
Motion from Dorothy, second from DT. Any question or discussion? Not all in favor say aye.
Aye.
Opposed, same sign. That motion carries. Thank you very much.
Thank you.
And that takes us to Mr. McGrady. Good morning, sir.
Good morning. You just listened to a very fortunate year. Unfortunately, there's a room full of executives lined up to try to spend a little of that. So, I managed to claw my way to the top, though. So, no, thank you seriously for the opportunity. This is a contract we presented back in July at some of the budget retreats, the two-day budget retreats we had specific to revenue cycle. Two of those, one of them was observation and lowering that observation rate. This particular contract deals with automation of revenue cycle processes, and today we are presenting a contract for Olive, who has been selected for that work. 23 respondents to the RFP. We are expecting, if this contract goes a full 5 years, we would see about $10.5 million in additional revenue or cost reduction. And that, of course, is going to cost us a little bit, about $3.7 million. So a net benefit to JPS of about $6.5 million overall. So we are spending a little money to make some money. Important to note that Olive is providing a minimum return of 3 times their cost. So what they are doing is if they don't provide the return, they will look for additional automation and cost savings opportunities. In the event that they don't find that, then they will actually lower their fees the following year. So we have some protection in there. Key areas of focus, we're really going to be looking at authorization processes and notice of admission processes. We do have some leakage there, and it's a very manual process, and it's got human error in it. So we're going to try to close some of that, close out some of those denials from insurance companies. Also going to automate some of those repetitive processes that we are doing that are kind of labor intensive. In closing, overall, we're very good at what we do in revenue cycle. We just need to be a little bit more affordable and more efficient, and we hope that this contract will help us do that. We're also excited that we are bringing a technology to JPS that we really haven't used before. We think it can be used in other areas throughout the system. So I would take questions or anything that you might want to add.
Any questions for Roy?
Roy,
Minimum 3 times
what is-
performance. Okay.
Yes,
I
sir.
can't find the word PI. What is PI?
PI would be performance improvement.
Okay.
And that's the 10.5 million that I referred to. And then, of course, the cost associated with that is 3.7 million. So overall net 6.5 to the system.
Will you be able to separate between their improvement versus your own process improvement internally?
Yeah, we'll put together the ways to track that from the standpoint of their specific initiatives. In fact, we have to track it because they're the ones guaranteeing that performance improvement. And so obviously there'll be some debatable questions there that we have to, there will be some debate, I'm sure, but we'll make sure we're on top of what they say they're getting credit for. Absolutely.
Because I would hate to pay them because our contracts negotiation is higher, or
Right.
we got sicker patient, automatically we got reimbursement higher than the actual process that they improve from it.
Yeah, absolutely. We will be developing a pro forma and ways to track that. We've got a little bit of time before everything kicks off here.
Okay. I like the penalty and reward there. That's a good
Yeah,
deal.
the good news about your question is if we find more in savings and cost reduction, we're not paying more. So our expense portion there is capped. And so every additional dollar we're able to achieve through this is a plus.
Yeah. Thank you.
We evaluate at the end of 3 whether or not we want to renew for 2
Yes.
additional years.
So it's a 3-year contract and the numbers I was speaking of course, were 5 years. We anticipate this would be probably a 5-year agreement, but we will evaluate it at 3, and that's when we would have an exit opportunity.
Perfect. Any other questions for Roy? If not, we entertain a motion. Motion from Zim, second from Dorothy. Any question or discussion? All in favor say aye.
Aye.
All opposed, same sign. That motion carries. Thank you very much, Rory.
Make a
actually, I
note of
have
Rory,
one.
though. He comes across as a real quiet, nice guy, but you notice he got his money first.
He was in line.
He got it first. He didn't care about anybody else. So you can see that side of him.
Exiting the building.
Roy, one quick question for you. Is the marketing agreement with them, joint marketing, what does it require us to do? Do you know?
Pretty much, DT agreed that we would approve anything that our communications department, anything that comes out of here would have to be approved by us. So we're not obligating to anything without approval. So we did talk about that in the negotiation. It's one of their, marketing statements in the contract, but we've got full ability to approve anything that they would ask us to do.
Because I'm okay with, reference
Sure.
for their performance, then, a lot of time they want to ask for reference and maybe a joint press release. But we have to be very careful because they are in a fundraising mode.
Right.
And I would hate to put our name on there for them to raise fund without, because they are in a little bit of
Yeah.
investment, or they operate at a loss. So they constantly doing fundraising, and I would hate for us to get caught up with that fundraising for that type of business.
Yes, you're correct. They just did a pretty major round of funding recently, as a matter of fact.
Okay.
All right?
All right, Roy, get out of here while the getting's good.
Yeah, get out. Yeah, exactly. Or board member.
Roman numeral 5C, consider approval of scope of work between Relate Care LLC and Tarrant County Hospital District Joy. Good morning.
Good morning. So this is a request to amend our current master service agreement with Relay Care to expand their assistance of receipt of inbound calls for scheduling. Our goal here is to help improve our average speed to answer and hold times. And so this contract comes at a cost of $1.19 million. This was approved, the cost associated in our budget. And of course, its initial contract is a 1-year term with the potential of 2 separate 1-year renewal options at the same rate. So
We've had them before.
So they are our current vendor that helps to support some nurse triage calls for after-hours support.
Okay.
It is nice that they have training of our electronic health record, our system, and then we have regular scorecard meetings with them around those specific KPIs and those expectations.
Good, good. All right, you've heard the presentation from Joy. Any questions?
Move approval.
All right, we have a motion from Dorothy, second from Zim. Any question or discussion? All in favor say aye.
Aye.
All opposed, same sign. That motion carries. Thank you very much, Joy.
Thank you.
Zelia, consider approval of professional services agreement, adult and adolescent crisis mental health services between MHMR and Tarrant County Hospital District. Welcome.
Thank you.
I won't call you Bama since Montgomery's not here.
Thank you.
I know he and you both wear that as a badge of
He
honor. I hate
does.
to elevate it.
So I'm a homeowner now in Texas.
Oh, congratulations.
So I'm a Texan, so
Congratulations.
so, you
Just
know.
be sure you pay your property taxes.
I don't think I have a choice, but I will. They're different than Alabama property
I
taxes.
bet they are.
But you get what you pay for, too. So the first contract I have for you is to consider approval of the professional services agreement with adolescent, and adult crisis mental health services between MHMR of Tarrant County and the Tarrant County Hospital District. This is a revenue contract. While Rory's spending, I'm trying to bring in revenue. No, I'm just kidding. It's for $2.386236 million. Annual revenue for a one-year contract, which is included in the approved FY22 operational budget. This allows JPS to be reimbursed for providing mental health services that are indigent, have no ability to pay, and we are reimbursed for those services. However, the reimbursement certainly does not cover all of our expense, but it certainly helps with our cost to do that.
All righty.
Do you know the delta between what the revenue and the expenses?
Do what now?
Do we know the delta between the revenue and the expense?
I don't off the top of my head, but I'm quite sure that finance knows, or could. But I mean, there is a delta.
Big,
I just don't know what that delta
Guarantee
is.
we are in the red.
very red or just slightly red?
I would not want to hazard a guess with the UDT, but we can get that information for you.
Less red than without the revenue contract.
Very red. Okay, thanks.
We will take everything we can get, though.
Absolutely.
And do you think we would likely be having some of these patients come even without the reimbursement from MH?
All righty, you've heard Zelia's report. Do I hear a motion? Motion by Zim, second by DT. Chet, you just got to be faster. This is like Jeopardy. You had to push the button.
That's a good one. Jeopardy.
We're going to wait for Chet on the next motion.
I may just move to approve without discussion.
Yeah. Give him the controversial one.
All right, did we vote on that or not? Did we vote on that yet?
Yeah.
All right, good. Okay, Zelia, I think you have the next one, do you not?
I do, yes, sir. So this is requesting your consideration for approval of another professional services agreement for inpatient mental health services for involuntary committed patients between MHMR of Tarrant County and the Tarrant County Hospital District. Again, this is another revenue contract of $6.113 million. Annual revenue for a one-year contract, which is included in the approved FY22 operational budget. This reimburses us for care that we provide at our LCA hospital that we lease, local commitment alternative unit. So individuals that live in Tarrant County that are committed civilly for state treatment go to these beds, and this allows us to recoup most of those costs. So it does carry a 90-day out clause with prior written notice.
All righty, any questions for Zelia? Well then, you have a question, Dorothy? No. Well then, the chair recognizes Dr. Chet Schrader to make a motion.
I would move to approve.
All right. We have Dr. Hurd who seconded that motion.
I'm just too quiet in the corner.
Any question or discussion? All in favor say aye. All opposed, same sign. Thank you very much, Dr. Schrader. And I believe you have item F, do you not, Zelia?
I do.
Okey-dokey.
So I'd like to ask the board to consider approval of an exemption to bid and psychiatric outside medical services agreement between Millwood Hospital and Tarrant County Hospital District. The cost of this contract is $4.480 million annually, which is included in the approved FY22 operational budget. There's a potential cost of $13.4 million, total cost over a possible 3-year term, initial 2-year term with potential 1-year renewal option. The strategic plan alignment provides JPS a safe and timely disposition of patients that are located in our psych emergency center and also located in the medical hospital on our medical floors, to be able to transfer them to another licensed secure psychiatric facility while maintaining a safe volume of patients in the psychiatric emergency center. The per admission flat fee payment is a change, and I worked with Rory in finance, and we took the length of stay with our patients at Millwood and came up with a flat rate agreement. And so they're at risk if they keep patients longer. It makes it better for us because we can shift resources of utilization management to focus on our JPS connection population as well. It also aligns with the district's goal to collaborate purposely to connect patients to psychiatric services that they need and improve access to inpatient psychiatric care. It does carry a 30-day out clause with prior written notice. We also included in this contract, which is new for our contracts as they're coming up now, quality metrics and quality expectations of Millwood Hospital.
Celia, does a contract like this change once the behavioral health hospital is built?
Yes, sir, it will. All of it will.
So you have the ability to manage these contracts in a way to be able to get out of a contract once those facilities are completed?
Yes, sir. All of our contracts have a 30-day out clause with prior written notice.
Fantastic. And I believe this is a two-part bid. Yes, that's correct.
that duty today.
I have a quick question before you go there. You mentioned that there's quality matrix that you can operate. Does that also include the population that I guess the outlier that stay longer? Do we know the outcome of that? Because I just want to make sure that they don't discharge them.
Correct. All of our patients that go there are discharged to our outpatient programs, and they have to be sent to the outpatient program on day of discharge, and we're able to immediately assess and evaluate that patient then. And if we see that there's issues like that, then we will certainly address that with them.
So you would know if they discharge, when they exceed the number of days that they have to eat that expense?
We would know the number of days they would have to eat, because we're still going to monitor that we've sent patient Mr. Smith there, and then we know when Mr. Smith discharges.
All right, thank you.
Yes, sir.
All right.
Okay.
Presentation. We need a two-part motion.
I have moved that we approve the exemption to bid and the psychiatric outside medical service agreement between Millwood and Tarrant County Hospital District.
Motion made by Dorothy, second by Dr. Schrader. Any question or discussion? All in favor say aye.
Aye.
All opposed, same sign. That motion carries. Thank you very much, Zelia.
Thank you.
We appreciate it. Keep up the great work. I believe Dr. Elliott is here. Welcome, Dr. Elliott.
Thank you. Good morning. I am here presenting you consideration for approval of exemption to bid and the Fifth Amendment to the Medical Education Affiliation Agreement for oral maxillofacial surgery is between the Oral and Maxillofacial Network and Tarrant County Hospital District at a cost of $384,480 over a one-year contract term extension. It is approved in our FY22 budget, and this will align with also the PSA. That also will expire November 30th, 2022.
This item also will require an exemption to bid, part of the motion.
I move that we approve the exemption to bid and the second, fifth amendment to the medical education affiliated agreement between oral and maxillary surgery.
Okay, motion perfectly and capably made by Ms. DuBose. Perfect. We have a second. Dr. Hurd, a second. Any question or discussion? All in favor say aye.
Aye.
All opposed, same sign. Thank you very much, Dr. Elliott.
Thank
We
you.
appreciate it.
Thank you.
All right, that takes us to item H, I believe, and Mr. Chung. Good morning, sir.
Good morning.
Good morning.
So I am here to present a dosage software license agreement between Baxter Healthcare Corporation and the district. Carries for about $103,000 annually with a 2-year contract term, which also includes some equipment and implementation fees associated with this. What this software licensing agreement does for us is really gives us a better capability to improve our in-process validation for all of our drug mixing that we do here on campus and at OIC. So we really feel like this is going to improve our workflow in addition to free up some much-needed pharmaceutical resources to do other things given the capabilities of this software. It is, again, a 2-year agreement. It's on Vizient GPO, and it does not include a no-cause termination provision. That is something that we were able to work with Baxter for a shorter amount of term, but we don't see that this is something that we would be wanting to discontinue in the next 2 years either. So, questions?
You have a 2-year contract term, $18,000 implementation, and is there a provision for extension beyond the 2 years or not?
We don't. The original contract that was presented to us was actually a longer term, and we specifically asked for a shorter amount.
Okay.
Because some of the Epic upgrades that are going to be happening within the next 2 years, we'll actually be able to switch off of this contract, which will save the district anywhere between $250,000 to $300,000 on the back end of that longer-term contract that was originally presented to us. So we felt like over the 5-year term, or that original term, was better to go in with a shorter amount and then switch to an already in-house product once that capability is available.
Makes perfect sense.
Is the 795 and 797 documentation for the 340B, is that new, or is that?
No, that's existing. It's just, we're still in compliance. We were doing all that. It's just very manual, and so this will improve that process.
But that will be separated between the 340B and the rest?
Yeah,
of it?
795, 797 separate, then 340B accumulation. Okay. Yes, sir.
All right, thank you.
All right, any more questions for Doug? All right, we need a motion.
Move approval.
A motion from Dorothy, second from Zim. Any question or discussion? All in favor say aye.
Aye.
All opposed, same sign. Doug, thank you very much.
Thank you.
And now we move to Mr. Lane, fire and smoke barrier repair.
Good morning.
Good morning, sir.
I see I'm bringing the most exciting one of the day in. Dorothy, there are advantages to being the chair. You don't have to make all the motions. So I'm here to present to you today. I'm just going to ignore that, DT. So I'm here to present Life Safety Systems smoke barrier repair. This is phase 2 of a 3-phase project. The first phase occurred last fiscal year in the Joint Commission repairs. This is phase 2. Phase 3 will be budgeted next year. This is a budgeted ask. It comes with a 30-day out and is to maintain and repair the integrity of our fire and smoke barriers as discovered during the IRMA project.
Pretty simple and straightforward.
Yes, sir.
Any questions? All right, we have a motion from Dr. Schrader, second from Dr. Hurd. I think the physicians have.
It's a race.
Yeah, I think they have.
Doctors have snapped
we
up
got
on
it.
the system and they have got it
They've
down
got it
now.
now.
All right, then all in favor say aye. Aye. All opposed, same sign. That motion is approved. Thank you very much, Adam. We appreciate it. In terms of the planning committee items, I don't know why it says Steve
I
Montgomery.
just looked at that too. That should not say that.
We should text him.
Be
on that.
questionable passage.
This is an item for Daphne, actually, on award of architectural services between Beck Group and Tarrant County Hospital District.
Thank you. I will offer no jokes in exchange for no questions.
Can't make that guarantee.
We are requesting approval to move forward with the award of a contract to Beck Architecture LLC for architectural and engineering services for the new behavioral health facilities. Just a reminder, we put materials out on the portal related to this RFQ a few weeks ago just for the board's review, and we'll continue that discipline as we bring forth these requests for approvals of awards to the planning committee. And then we will request approval before we move forward with finalizing the contract, which will be presented to finance and planning. The RFQ for these services was concluded in April of this year. There were 12 respondents, and Beck rose to the top in the scoring. They are national experts in behavioral health with a renowned list of subcontractors and anticipating roughly 22 to 26% hub participation with strong experience on similar projects. So since you guys have agreed to forego questions, if I can just go ahead.
Can we, since we're,
Thank you.
Daphne, since we're meeting jointly, does this have to go back to Finance Committee, or does this constitute the entire motion approval?
So this is just approval to move forward with the award. So
I see.
we've not presented the
Okay,
contract
so
to
the
you
award will
all yet.
formally be on the Finance Committee item. then.
Correct.
Okey-doke.
The contract will come forward.
All right, well, Daphne said no questions. I'm sorry, I screwed up. Dr. Hurd's making a motion. All right, I have a motion for Dr. Hurd to award the RFP is
The award,
finished,
yeah.
is out in the award, okay. And a second from Dorothy. I saw her hand first. All right, any question or discussion? All in favor say aye. Aye. All opposed, same sign. That motion carries. That is our regular agenda item. We have a 5-minute, maybe 5-minute executive session item. So if you guys in the booth could give us a couple of minutes to get reconfigured and y'all hang out, take a 5-minute break if you need to, and we'll come back and conclude this in plenty of time for the governance committee to get their work done. Like, I don't know, hour almost.
Yes.
40 minutes. Roger shouldn't be griping. Is coming back from executive session. I'm informed of no action to be taken. We appreciate all of you being here today. We'll consider ourselves adjourned at 11:34.
what is that, 28th? 28th, okay? We do not have any citizens to address the board. The next on the agenda will be the approval of the minutes. Okay, been moved by Zim, second by DT. All those in favor of approving the minutes signify by saying aye. Those opposed by nay. Motion passes. Okay, we will go into our agenda, and the first up is update of compliance with Colin. Okay, thank you.
We are joining the room today by our new Director of Compliance, which I announce, Miriam Glasser, is joining us. She is a compliance program operations subject matter expert. She's bringing to JPS a wealth of experience in areas like conflict of interest management. She'll be taking over our hotline, policy and procedure. She has a Juris Doctorate from DePaul University in Chicago and a BA from Indiana University, so another Midwesterner joining our compliance team. We are excited to have her. I have put her to work immediately inside of her first work week here, and we'll keep her quite busy.
So 2 major degrees, she's an underachiever. We're expecting a lot more from her.
Exactly. The bar is extremely low here. Also joining us, and I excluded her name just because we needed to put this out prior to the meeting, our senior coder auditor joined us on Monday. Her name is Julie Pratt. She comes to us with more than 20 years of experience as a certified coder, a wealth of experience in the auditing space. We are lucky to have found a candidate with her credentials and her bona fides, and we snapped her up immediately. We are excited to put her to work. I have a whole suite of audits ready for her and waiting. She is a relationship builder. She believes in education. She is everything that we want compliance to be as we look to partner with our H&M department on the revenue cycle side, specifically in the hospital-based coding space. So with those 2 hires, since the last time I appeared before the board, we've cut our vacancies in the governance division in half. So we do have 2 left. We are still openly recruiting for our privacy officer role, which is a manager level role, as well as a senior compliance analyst position. So we hope to have some qualified candidates and fill out our division in the near future. So I want to talk today a little bit about the governance work plan, which I brought to you and will submit for approval in just a little bit. This represents some changes from how governance, compliance, and internal audit operated in the past. This is a unified work plan. It encompasses both internal audit and corporate compliance, and it does run on a risk-triggered plan. So the new expectations for our annual work plans is that we define our risk assessment methodology. So we provided this. I hope everybody had a chance to look at it, but it is well-defined inside of the actual work plan itself now. We want our risk assessment to reflect the totality of risk for our lines of business, and that would include anywhere the board has budgeted money. From my perspective is my domain, so that would include JPS, Acclaim, and the foundation. And the totality of risk includes the entire suite of regulators which are listed in the work plan itself. We are looking, I think, upwards of 40. We do a 2-year look back at all of those regulators for enforcement actions. We look at their work plans, we look at their guidance documents that they're issuing, and then we'll do periodic reviews to make sure our register builds on itself over time. We want to make sure also that our highest risk items or misconduct that we may uncover during the course of the year results in compliance action. So this plan is supposed to be, as intended to be, fluid. It should change to reflect risk. We have always used in the governance division a likelihood versus impact model. The only real modification here is that the scoring tiers have been increased in number just to provide greater definition amongst risks as we do out the risk register. So as we started the new direction, I think it was helpful to kind of review from where we came. So, flip that for you. So in the past, we had used a 23-point system here to determine what constituted a risk at JPS, and then from that, you would be provided a list of 10 or so items that we would look at during the year. That, from my perspective, and I've done risk this way before in compliance, provides somewhat of a curated view of risk. I am largely dependent in this model on staff interviews and staff being honest about what their problems are. You get a lot of perceived risk in here, which may not constitute an actual risk to the organization. And so we're trying to eliminate some of that with this new approach to compliance and auditing. Some of the main comments that I heard as I kind of roadshowed with my peers here in the first couple of months on the internal audit space and the compliance side, and the things we were choosing to look at is, I'm not quite sure why we were looking at this in the first place, or I'm not certain that it represented risk to JPS. And those are comments that I take to heart and want to really demonstrate in the future why we've chosen to look at something and then provide the data which backs that decision. Yeah.
So, we deal with this a lot in medicine, but how do you separate the qualitative from the quantitative? And how do you, what's your, perceived risk of perceived versus real?
So, yeah, anytime I can quantify something in terms of dollars, that makes sense to me. We can usually always get there, especially in the finance and coding space. We will isolate samples and then produce an error rate based on that, and then that is used to then quantify dollars, and we'll include in their prospective fines that will be associated, False Claims Act fines, any penalties we perceive, and then that is where we start multiplying. There are types of risks in the compliance space which cannot be quantified that way, and so inside of the work plan itself, we built in other kinds of matrix. So there's brand impact, for instance, or on the cybersecurity side, a different sort of model. But we will put data to it when we can. And if we cannot put data to it, it just won't be scored. It'll sit there until we can provide a metric to measure it by. Does that answer your question?
Yeah.
Okay.
It's intangible. Yeah, right. It's intangible. Our risk register, which I have provided in hard copy format and very tiny print today for you all to enjoy, actually looks better in an electronic version, which I'll provide after the fact. And in the first column there, it will contain hyperlinks. It'll tell you where we sourced the risk. It'll take you right to why we perceived it to be a risk and then want to go ahead and quantify it in terms of JPS. So all of these things here are not actually occurring at JPS right now. This is what we believe the healthcare landscape from the last 18 to 24 months in terms of compliance and audit risk should look like. It's got 150 items on it because we had to cap it at some place. Otherwise, it would have like 600 or 700 things on it, judging by how quickly the healthcare space changes. So we will start with 150, and then again, it'll build on itself over time. In assessing the regulatory environment, we want to do this at regular intervals. It is targeted right now. Every 2 months, we'll go back and look at all these regulators and add to our list. At that point, the ledger of risks, which is what you have here, will continue to grow. We want to drill down on risk in terms of JPS and Acclaim. I want to look at the entire enterprise. Their compliance team at Acclaim has been great to work with to this point and has accepted some audits that I've sent to them already. I appreciate their partnership. That is one that we will build over time. The same can be said for our HIM revenue cycle team. Great relationship with those folks. We'll use a combination of internal and external auditing. We want our internal teams to be able to justify how they've coded certain things, and then we want external eyes on it as well. We want to apply a consistent and standardized scoring methodology that's laid out inside of the work plan itself. We adhere to that pretty consistently here. I could have scored 10 or 15 more of these items before the meeting today, but there's no reason to rush this. I think we'll have plenty of time to score risks over time. We want to make sure that it's done right. In scoring risks, when we have our sample, when we have our error rate, when we get our response back from our external or internal coder team, it goes over to HIM and they can rebut those findings. And then we have the finalized score. So it's a multi-tiered process to set up how we think risk is in terms of the error rate, and then we use that to quantify dollars.
But this is just a list, right?
That's just a list.
It's not prioritized?
It's not prioritized right now. And the list will always be made available to the board. I think you should always have access to it. You'll certainly see the top 5 at any given time. Every time I present to the board, that is what we'll focus on. You can ask for the top 10. You can ask for the whole list that we made available to you, along with how we've scored it and all the data we used to score it. All right, our updated methodology for compliance and audit is a risk-tailored resource allocation model. So what that means is instead of picking 10 items at a point in time, which would usually be today, and then working on those during the given year. This allows us to continuously reprioritize things as they come up. And as items fall off, new items will come on. And it is not uncommon, as we work on a risk, we uncover risks that are ancillary to it, and we start working on those. That's already come up as we've started to score risk. For the current top three, for the corporate compliance side of the house, these are all legacy risks, ones I inherited when I walked through the door. Some of these should probably look familiar to the board, and we will work on these. We have pulled analytics already on all three of these, and then built samples from those, and they are currently being assessed for the current risk to JPS. They are scored on the risk register, but it is using the legacy data, and I wanted updated data, quite frankly, and so that's the direction we're going in right now. So it may be that these risks slide down from where they are or go up from where they're scored, but for right now, I had these three on the books, so we'll start with these three and then add more. The internal audit side of the house.
Excuse me a minute.
Yes, sorry.
Quick question for you on item 3 there. Since it's happening twice already, do we know the root cause analysis on that one yet? Or can you take a look at that? Because I'm more concerned about the root cause than being in compliance and then we're out of sync again.
I agree with you. We will look at, I've got it chopped up a number of different ways, so we're coming at it from different directions. For example, specific CPT codes that involve these modifiers, our top providers, we've got it broken out between JPS and a claim. So we're going to start to drill down on where we think the actual problem is, and that would be by modifier. So we'll look at each one individually.
Okay. Because some of it you may see differently from the host system, and then there's a bridge routine that stays outside of the Epic system that goes to the insurance. I just want to make sure that what we see on there is not the same thing as what we send out.
Yeah, it is clear from the coding, from just what we've seen so far, that there is some of that going on, so we're aware of that and we're looking at it.
Is there any way we can find a way to categorize if there's a bridge routine that was being put in to bypass the system? There's a time expiration, or at least, a inventory of what we custom put in, so that when the rules change, we can pull it out, or...
That I don't know, but I can follow up on that for you. So just to make sure I understand, you're asking if there's an automated process living outside of the coding process, which is leading us to code things a certain way.
Right, because we have to have a hard fix, because sometimes too many subsystems.
Yep.
And we got to stay in compliance, but sometimes that thing expire or it changed, the rules change, and then it hard coding that we didn't know about.
Gotcha. I'll bring that back for you.
Can I ask you a question about number 3? When you say improperly appending billing modifiers, that suggests that that's done post-visit after the clinicians actually put the billing in?
Correct.
Okay.
Any other questions on that, on those three? Okay. On the internal audit side, these are, they tend to involve more than one risk, so they are more complex in nature, and thus we need to lay the plan out a little bit further in advance on the audit side than maybe the compliance side, where it's more reactive. So we have, one of the goals of the work plan this year is to do a deep dive assessment of our existing corporate compliance program as it's constituted today. So the first audit really out of the gate for them is an audit of me. I cannot audit myself, so actually Daphne is overseeing that particular audit from our internal audit team. So I just wanted to make that clear to everybody that I don't believe in self-audit. So they will assess the strengths and weaknesses of our compliance program, and that will likely result in future policy changes. But I think it's important to set the precedent that if we're going to come and change the entire way we do business here, it's important that we show our work. And so that's what this is about. They will assess the other 4 here of these. I think right now they start out relatively broad. As we move on, and Tim will explain this a little bit further, we'll kind of narrow the scope on some of those to look at specific items, and it will map back to risk on the register as well. All right. So that being said, I will stop, and I know it was a more complex document that is normally provided from the individual in my role than has previously been seen. So if there's questions on the work plan before I even ask for an approval of it, I'm happy to to answer any and all questions as they pertain to this year's compliance work plan and audit work plan.
Okay, there doesn't appear to be any questions, so I will entertain a motion for approval of the updated plan.
Move to approve.
Okay,
Second.
all right, got it. Okay, it's been moved and second. All those in favor of the work plan signify by saying aye. Aye. And those not approved by nay.
It's the method to the madness right there.
I do want the minutes to reflect that Colin said, after Mr. Nguyen asked a question, Colin said, "Are there any other questions?" And DT said no. So if I could have the minutes reflect that, it is a historic day. And we also think, DT, that you and Colin, like a dog whistle, can understand each other, because y'all were just going at it with questions and answers, and we were just sitting here thinking, I bet they're talking to each other. So that was hugely helpful.
That made perfect sense to me.
Well, Colin, it is quite different than what we've received in the past, but I am impressed with all of the information that you are providing, okay?
And I
All
hope
right.
that will continue over time.
Okay.
I second that too.
All right. So we are now ready for the review of the charter?
Yes, so the change to the charter, and this requires acceptance but not approval, is that a correct statement? I believe is what we decided upon. The board needs to accept the changes to the charter? Okay.
Yeah.
The change more clearly delineates the membership of the Executive Compliance Committee, spells it out by title, and then more clearly shows who votes and who does not vote. It was my desire to expand the participation of my peers amongst the Executive Compliance Committee. I value their input. It also has the byproduct of producing some more accountability amongst our teams for compliance. So that is the primary change that was made to the charter.
Okay, anyone have any questions? I didn't see a lot of change. You know, I just go to the red line, and the changes were minimal, so if there are no questions, I will entertain a motion for approval. Okay. Moved by Zim, second by Amanda. All those in favor of the changes to the governor's annual work plan signify by saying aye. Aye. Those opposed by nay. All right, thank you. Since you are, okay, so we are ready we have nothing else for open session, right? So at this time, we will end our open session at 12:26, and by 12:30, we will be in closed session.
I'm sorry, we do have one internal audit update for the open session.
Okay. Did I miss that? Okay, I'm sorry.
I think they might have moved it up.
Let's see. Is this the one I was looking at? Okay, I'm sorry.
Good afternoon, everyone.
Tim, before you start, Colin, can you clarify where you are on the agenda?
Yeah.
Is this item
So this would have been probably 2B.
2B?
2B, okay, all
But
right.
the
I'm sorry.
slide deck got shuffled
All
out.
right, okay.
So the first update I wanted to share with the committee is around our audit client survey results. So at the end of every audit, we send out an anonymous survey to the folks that we worked with on the business side during the audit to get feedback on how they thought the audit went, whether it went well in their opinion, whether they had suggestions for improvements. We always like to solicit that feedback so we can review our internal processes and make changes going forward. And then periodically, we'll bring that back to you all at the board and share with you the results and discuss the feedback that we received. And so for FY21 on the slide here, you can see for these 4 projects where we sent surveys, you can see the number of surveys that we sent out, the number we actually got back with feedback, and then down below is a chart on showing the average score per audit and our benchmark goal. So in years past, we had a goal of 4.25 out of 5, And we were consistently meeting that or beating that, so this year we raised that up to 4.6. And you can see for these 4 projects, we exceeded that for 3 of the projects, but there was one on the telemedicine where we did fall slightly below. And on the next slide where we talk a little bit about the free text comments, I'll touch on that a little bit more.
Could I ask a question about on the return rate? Do we just email it to them, or how do we try to get more folks to respond?
Yeah, and this has been a longstanding issue as far as sending out several and not getting a ton back. Last year we had talked about having the chief compliance officer. So let me back up for a second. The process is I will email out the survey, letting everyone know here's the link to the anonymous survey through SurveyMonkey. Very short, 7 questions, and an opportunity for free text should take just a few minutes of your time. And then I can see as the results are coming in, and as you can see, it's typically not a huge return. So what we talked about last year was a few different options, one being having the chief compliance officer call the folks that we sent the surveys to just to remind them that it's still open. We really want and encourage your feedback. And so that was happening with Colin's predecessor, Ron, and Colin and I have talked about continuing that going forward. And I'll also send out email reminders too, just to the full group that I sent the surveys to originally. So currently it's email reminders and calls. Definitely open to suggestions, if you all have other thoughts or anything we can do in addition to that. I will say from past experiences at other organizations, this is something that we typically struggle with, is getting the feedback solicited.
Okay.
Yeah, actually, with the numbers that were sent out, I'm actually surprised that you got any.
Yeah, and I think one thing we talked about last year too was I think people that had a really bad experience or just a bad experience are more inclined to, fill out the survey, voice whatever frustration there was. So that, assuming the feedback is generally positive, that could play into why we're not, seeing as many as we send out.
You ask for some suggestions. Sometimes what increases response is if it can also be done on the phone rather than sitting down at a computer or tablet. So sending out a link that can be also used on a phone app. We've been trying to change to some of that and hopefully see an increase in response.
And that's a great point. So I think with our current process, you can do it through the phone through SurveyMonkey, but I think I should make that clear in sending out that you can do this on your phone. It doesn't have to be done through a desktop. Yeah.
Yeah.
They did. That was, yeah.
Yeah, they were happy in telemedicine. They sent 6 back.
I don't know whether you've noticed or not, when foundations are sending out for donations, one of the things they do that kind of makes you say, okay, I got to come back with it, they put a stamped envelope in it. And that tends to encourage somebody to go ahead because it's not an investment that they have to do in anything, but just put it in the envelope and send it back.
Right.
Okay.
So how do you, 2 questions, how do you determine the number that's sent? So how do you, how do you come up with your N value, right? Yeah. And then 2, if it's internal, assume that in the first one, the provider credentialing and privileging went to providers. Is that who is that who you had surveyed?
Yeah, so, and maybe to touch on your first question, how do we determine who to send it to? It's really anyone we worked with on the audit, from the executive, the accountable executive, all the way down to, it could be an executive director, and then on the team, who we actually worked with on the team. So you'll see on telemedicine, there were quite a few sent out because that audit actually touched on several different departments and areas on both the acclaim side and the JPS side. So that's why there were a little bit more there. Now in provider credentialing, that was really focused on the medical staff services team. So at the time, Cindy, Dr. Elliott would have gotten a survey as the accountable executive, and then there were two folks on her team that we were working with from a day-to-day document request process walkthrough.
Okay, just to clarify, so this goes to the department that provides the services?
Yes. Who are we auditing? Who are we working with on a day-to-day?
Thank you.
Sure.
Any other questions? Okay.
All right, so, and as part of the survey, there's 7 multiple choice questions, but then we do ask at the end, give an opportunity for free text, and the question is, what did you like or dislike about the audit process? Now, not everyone will always fill something in here, but what you're seeing here is for the surveys that were sent out, any free text response you're seeing on the screen here. So I didn't cherry pick, what to include here. This is all of the free text that we received for those 4 projects. Many of them are kind of what we're usually used to seeing: collaborative, supportive, professional. And then going back to the telemedicine audit, which was the audit that fell a little bit below our target of 4.6, you can see through some of the comments there that we did get some constructive feedback on report clarity. There was one person that mentioned that they weren't sure the auditors quite had the knowledge, in differentiation between claim processes versus JPS processes. And so that audit in particular, that was actually our first project with KPMG. So we have 2 co-source vendors, KPMG and Crow. The telemedicine project was the first one we worked on with KPMG. So I really viewed that as a learning opportunity and circled back with the KPMG team to go through the feedback we received, both the scores and the free text here, to talk through some of this constructive feedback, because we're still building that relationship, and as we use them going forward, I definitely want to make sure they had the feedback about, from our stakeholders, and talk about how we can improve that going forward. Any questions? All right. Okay, and then our proposed FY22 internal audit plan. I know Colin just touched on this a few minutes ago. Now, just to be clear, so because our current risk assessment and risk register is in progress right now, this plan was developed using our old risk assessment methodology. And I think one of the things I'd point out is, as the risk registers fully developed, matured, it's going to be an ongoing risk assessment process. We really hope that this plan is more of a living document. So as the risk register shows that maybe we have an emerging high risk that's not included in our plan, we want to have that flexibility to kind of be nimble and adjust as needed. If there's some high risk that we really need to look at now, and maybe it takes precedence over one of the projects that was on the plan, and what we plan to do is come back and share with you any changes and explain the rationale and why we if changes are made, why we decided to do that based on the current risks. So you'll see here, like Colin mentioned, we have an audit of the compliance program. We have 2 in the revenue cycle space around patient registration and charge capture, IT, 2 projects around cybersecurity and mobile device security. Cybersecurity, this was a deferral from FY21 that we had talked about at a prior meeting, but cybersecurity is just such a huge area. We could spend all year doing nothing but that. So we're really going to have to work with Curtis and probably our partners at either Crow or KPMG to really hone down on, the right scope and, for the risk in that area.
And I point out over time, we'll talk a lot about the finance and billing and coding space and the compliance side, at least in the start here, the first 18 to 24 months, and then eventually that will really be overtaken by cyber risk, which those 2 areas represent the bulk of what we're going to look at in the governance division moving forward.
Are there any questions? Do we need to approve his overall plan?
You just had that was just a report out, and Colin's already gotten approval of the work plan.
Oh, okay. All right.
That's all I had for open, so I think that
Now we're
concludes it for open.
All right. Now, we did do risk, I skipped a bunch of things, just want to make sure we covered your risk register. Right.
So the risk register, and the only thing I would point out about this, and again, I will send it electronically to everybody because it's easier to consume electronically, is that not all these things are happening at JPS. This is wherever you're consuming your healthcare news from. I think you often would have the propensity to ask, or anything like me, you see a physician in South Florida that gets fined $80 million, and you go, I wonder if we're looking at that. Yes, this is the answer to that question. It's yes. We take a look at that. We put the risk on the register, and then we figure out what kind of physician he was, what kind of codes he uses, what the type of fraud was, and then we go and look for that at JPS in a claim. And from there, that's how we determine, maybe it's for us, no risk at all. Maybe it's a high risk. If it's a high enough risk to be in the top 5, then we start working on it. And that is an ongoing process. So you have a lot of things that look a little scary, and quite frankly, the healthcare regulatory climate can look a little scary at times, and we need to be nimble enough to be looking at all of these things continuously. That's the idea behind the register, and that's the real focus, is to get to a risk-based analytics compliance and audit program, which is where we're headed with this. It will be not done today. This will be a series of evolutions over time in how we modernize our compliance program, and then at the end of the day, the risk register is a living document.
I have a question for you around 2 subjects. One is the cybersecurity and ransomware type thing. I think we're doing a pretty good job internally, but then we do have other vendors that are providing services. At what point in time would you guys consider making sure that there's either high trust or SOX 2 Type 2 compliance? I would prefer SOX 2 Type 2 because it's all audit from their process, not just high type.
I think one of the things, and we talked a little bit about the objective of assessing the existing compliance program, one of the gaps that's going to be there is our ability to perform third-party oversight, and that would include vendors and assessing vendors. I think that's become part of the contract process when we onboard, is that they receive a cybersecurity assessment, but that doesn't clean up the past, right? So we still need to go back and have a mechanism to determine red flags for vendors in the same way that we would do a criminal history records check or an exclusion list screening for an individual that's going to work here. That needs to exist in the third-party vendor space. We won't get there in the first 12 months, I can tell you. It's too much of a beast to try to get to, and we have other risks on the field. Our risk register does include specific cybersecurity things that would involve what you're talking about. So we'll isolate and look at specific instances, and there will likely be vendors on there that in a cyberspace risk assessment score fairly highly, and then we need to make a determination of what is our risk tolerance for that. At what point do we stop doing business with them versus, risk reward to JPS for a claim. But those are probably more complex discussions that will take place further down the road, unfortunately. That's the answer.
Let me ask the second question. Is just more for just to see where you guys are from a going forward risk tolerance type thing. I think we're at the point where there's a lot of software vendors that are using AI or RPA and all that stuff. And if we don't have a strong QA, we're going to be a world of hurt because we don't even see the data on the other side. I'll give you an example. Let's say we just approve in finance the new software to look at broken process, different way of coding and all that stuff. Those that some of the main things that they want to change, do we have enough internal control to know which one is process improvement and which one actually cross over to compliance challenge? If we miss that opportunity, we won't get it until CMS show up at our door down the road.
My inclination is to say that we have the capability on the analytics side to drill down on that, even as an AI solution would be improving processes. And when I hear improving process, I hear optimized coding. So I'm aware and cognizant of all that, that we're trying to increase revenue. When you do that, it's important that as we track the spend for that, as Rory was talking about, that we start diving into those claims. We have the appropriate people, both internally and a vendor that we brought on board to audit that space to make sure that what AI is telling us to recode is actually legitimate. So that I'm confident in. Can we do that on as wide a scale as this solution might implement? I don't know the answer to that question because I don't know what its immediate impact is going to be. There's also the opportunity for us in the governance division in the compliance space to bring on our own vendor of same type in order to be monitoring that, which seems a likely solution.
Because, I agree with the direction where our finance team is going with the coding and all that stuff for process improvement. but it's always keeping me up at night for the fact that
Keeps me up at night too.
the vendor is actually an expert in NSA. But we've been around long enough to know Lean Six Sigma and all that stuff. It works only if you have the right gray-haired people in the room to say, this is because of this and that. You can't just take the streamline the process.
Right.
And if we don't have that control in place, it may trip us down the road. And it's our fault because they're gonna ask us for approval. We will approve it and without knowing the consequences, because nobody's there. Only the doctor knows that it actually performed or not. So it's compliance, or it's appropriateness checking. And so just want to raise the attention to make sure that we don't have to clean up the mess down the road.
I come armed with a healthy skepticism of people who offer us coding optimization, because that's my job.
But we need it though, because we need to bring our workforce to the same. Okay.
And I want to see us be right, and my word that I use around the coding and billing space is accuracy. It is what it is. As long as we're accurate, we're good. When we start worrying about trying to hit percentages and stuff, that's where we kind of start going off the path that we should be on. So we keep an eye on those things.
Appreciate it.
You've got 6 categories up there that are in your work plan. Have you taken this risk tablet here and put them under those various titles?
Not on the internal audit side yet, because we have not scored enough to get there.
It might show you some stuff if you see that all of a sudden you've got 30 under one category and 2 under another, so.
Using the broad category cybersecurity, just knowing what I know about compliance, makes me a little concerned, because the term cybersecurity encompasses about 78 different things that we could look at individually, and that's probably the direction that we'll head in the future.
But it's not bad, lump them under one line,
Right.
and then if you want to subcategorize, you can do that.
Any other comments or questions? Thank you. Okay. Sorry I skipped you.
Oh, no worries.
I apologize, okay?
We'll tell the leader that you were a poor replacement.
Depends on what time we finish this meeting.
Okay, now.
I know what time it's finished.
Now I'm ready to close the open session at 12:45. And so y'all want to take a few minutes and then we come back for closed session? Yes, I know you do. Thank you.
That's a sign of a democracy, right?
It's some form of